Okay, so where is our table number one? Yeah. Table number one. You were talking here about all the different new arrangements. How will they coordinate and work together? So who's going to answer this one?
With difficulty. Just to, I suppose, one of the things we finish with, which I think is quite a good place to start, is what my colleague has called always events. And that is focusing on things that should always happen in terms of the relationship between patients and those who are caring for them. But just to look at the system, or the multiple systems that we have at the moment, there is a real problem about lots of silos, lots of people working in the same area, for example, trying to achieve the same objectives with different levels of enthusiasm, competence and interest. One of the things that sort of came up in the group was the what was called the tenacious process, and that is the ability to map out what local needs are, to work out how to align those different organisations that are working in the field, looking for gaps and trying to identify how those gaps can lead to improvements in services.
Who takes that overview of tenacious process then? Who does the knitting?
Well, the Health Watch is going to be the body which is going to be funded both locally and nationally to do that. And the important thing is that the Health Watch locally and nationally should be independent. And the problem we have at the moment is that £60 million is promised for the development of Health Watch, but that £60 million will not be ring-fenced. And we've got a real problem over the past year with the local links that had responsibility for bringing all those different aspects together, have lost vast amounts of money. And so we've got to find out how to ensure that we have stability in the system so that Health Watch in the future will be able to carry out those functions. A big problem is that local Health Watch will be accountable to local authorities, funded by local authorities, and also scrutinise local authorities, which is going to mean that their independence is going to be very, very frail. And similarly, Health Watch England is going to be located in the Care Quality Commission, which is going to make it also into a body which will lack independence.
So do you think then that responsibility for joining this up and making it work really sits at the local level? Between Health Watch and the foundation, they have to make this whole system work.
It has to be at a local level. People locally have to develop systems which are effective and sensitive, and the patient voice needs to be out there so that it's possible to translate that into service improvement. But going back to the word tenacious, it's absolutely essential, and perhaps many of the problems of the past have been due to the fact that people have sort of hopped in, got a bit of information and hopped out again, when what we really need is tenacious organisations that can continue to observe the quality of local care and can make sure that improvements take place when they're required.
I mean, it's interesting because we should be glad in a way that there are all these different bodies now that have got an interest in the public and patient views, but as the group in there has reminded us, it's just very, very fragmented. There's too many different organisations, and maybe it needs to be simpler. So finding ways in which we can simplify the way it all works is a key point. So.
Just add that around, what's the role of local organisations versus national organisations? And I think one thing that we stressed in our discussion was the need for kind of data standards and agreement between organisations about what they were measuring, what they were looking at, to have that sort of robustness across the system. And I think there's a duty on national organisations to provide usable, robust information to local bodies that they won't be able to collect themselves for resource reasons.
And did you see that there's also a role for the sort of stories and qualitative stuff that patient opinion and others are collecting as well?
Yeah, well, let me just finish up. Yes, I mean, very much so. And one of the problems is that data goes in all sorts of different directions. And what we really need to do locally is to bring that data together so that we all know what each other are doing and can have influence on service improvement.
Just thinking it from a national perspective, just some very, very obvious things. All the new national bodies, the Commissioning Board, Monitoring Centre should make a public commitment for how they're going to use the best practice in terms of sort of things we had Julian talk about in their work, so they publicly commit to being connected to absolute best practice. They should commit to doing that together, at least in certain circumstances, so they're talking about the same issues, the same data, and coming to a shared conclusion. And they should have that conversation in public, so that they are talking about the state of the NHS, for which they're jointly responsible. They might think about how they sponsor the availability of the sort of training that Julian talked about being available to his board at a large scale, so that we would make sure that every board, every set of governors, every health and wellbeing board had access to the best standard of training and expertise that we could. They're very prosaic.
Absolutely, but the training did sound like it was quite inspiring.
One thing that was on the slide, but may have been discussed on the table, but wasn't mentioned just then, was the role of councillors on the overview and scrutiny committees. And councillors have got a particular role and remit which is democratically mandated. So I think there's a responsibility on those council committees to make sure that a lot of this local assurance stuff is joined up. And in two-tier, or in areas of the country where there are county councils and district councils, I'm wondering whether there's a kind of different level of responsibility that we could suggest, where perhaps county councils are focusing much more on the strategic commissioning, health and wellbeing board stuff, and perhaps in light of what happened in the two-tier area here in Staffordshire, the district councils could be focusing more on the patient experience.
Because they're much more local.
Yeah, and maybe not just in acute trust, but also the quality of primary care and the experience of people in primary care.
Jamie,
just something on who are the players in the field, because if I'm from Health Watch, I talk about Health Watch. If I'm from patient opinion, great, I talk about patient opinion. Let's stop blaming everybody else and saying we are the only ones who can do this. And my vision is that actually we've got parts of the system, the local groups here in Staffordshire, people like Cure the NHS, people who have got real patient voices, where do they figure at the top of our systems? So the challenge for the commissioning board and others, a challenge for us, is how do we get the system working from them outwards rather than the other way around. And I think we've all got some responsibility and quite a lot of money actually to be able to do this.